turn down Tears for Fears here. This is Dr. Mitchell, everybody. Driving back on the 10. I had to work this Saturday. Unfortunately, or fortunately, depending on what way you look at it. Unfortunately, I had to work in a general care clinic, so a lot of age-related degenerative wear and tear type stuff. Not my cup of tea, kind of boring for me. I'm not a regenerative medicine specialist, send them all there. But I do like rheumatology. That's where I specialize. And so I did get to see some interesting rheumatic cases this morning. Handful of them. I'm only going to share one with you because I'll be talking for 3 hours and everybody gets bored after 3 minutes. So let's talk about this case. Middle-aged man comes in, shoulder pain. Okay? Sir, how long has your shoulder pain been going on? 8 months. What happened 8 months ago? I started CrossFit, and that is certainly what it is. Perhaps it is, sir. So I take a history. I'm getting kind of bored because I'm getting the sense that he's right, and this is a wear and tear type condition. Review of systems. He checked nothing. He says nothing. Okay. Sir, does anybody in the family have anything going on? Arthritis, autoimmune disease, cancer, anything funky? No. Rheumatoid arthritis, lupus, anything. Thyroid disease? No, no, no. Okay. Any past medical history in you? Anything you're dealing with? Cholesterol, blood pressure, anything else? No. Any drug allergies, sir? Sulfa, anything? No. This person is braking too hard in front of me. Any medications you're taking? Outside of for my cholesterol and my blood pressure, I'm taking a handful, but I don't remember what they are. Fine. All right. So I've already drank in the wear and tear Kool-Aid and CrossFit as the culprit. I'm swigging it. I'm downing it. Until I stand up and I get ready to do my physical exam and I'm about to take vitals. And I'm about to smack him in the forehead with my temporal thermometer when I see something around the outside of his scalp. What is that? I look a little closer. I identify psoriasis. And then I look down at his arm as I'm about to wrap his arm in my blood pressure cuff. And I'm like, what? What? I mean, that literally was not my response in the moment, but the little kid in me in my head was like, what the F? How is this guy not aware of his psoriasis? I mean, he literally had a giant patch covering his entire extensor surface of his forearm. I'm touching my right, it was his left. And just looking at that, it was pretty significant psoriasis. Maybe like 6 to 7% PASI score. That's what we use to track disease activity in psoriasis, total body surface area. And I look down at him and I say, sir, I thought you said you had no medical history outside of your cholesterol and hypertension. And he goes, oh, I got a little psoriasis. Yeah, a little psoriasis. Where else is your psoriasis? Well, it covers most of my legs. I've got some on my back. You saw it on my scalp. Maybe around my ears. Maybe there's some in my butt. I don't know. Okay. Well, I'm not going to look at your butt. But do you have any other joint pain, sir? Well, first off, are you sure your shoulder pain started 8 months ago? Maybe. Are you sure? Yeah, have you had shoulder pain in the past? Well, now that I think about it, it's been going on a lot longer than 8 months. Yeah, maybe a year or two. Okay, do you have any other joint pain, sir? Yes, one of my ankles hurts, and my knees hurt, and sometimes my hands. Okay. Oh yeah, and my knees, they swell up, like fluid in them, like little melons. Okay. Do you have any morning stiffness, sir? Yes, and it's mostly in my low back. How long is your morning stiffness? Minutes or hours? Oh, it's easily hours. Every day? Most days. Okay. Where in your low back are you having the stiffness? Above or below where your pelvic girdle starts? Below. Okay. Probably his SI joints, or one of them. All right. Oh, Dr. Mitchell, by the way. Yes, sir? My primary care thinks I have gout. Why does your primary care think you have gout? Because my uric acid is really high, and some of my joints hurt. Okay. How did she determine you have gout? With my blood test. How high was your uric acid? I think it was higher than 10, like 15 or 16. Did she drain any fluid from your joints? Any swollen joints? No, she did not. A note on gout, you can diagnose it clinically. I've done that, but the history is more crystal clear than it is in a case like this, where you've got an overlapping, probably rheumatic condition. Got to tap the joint. Usually it's just a dude with diabetes and nothing else going on, clean history and a high uric acid and joint pain. That's probably able to be diagnosed clinically, but not in this case. Got to tap the joint, got to look for crystals. Okay, back to the case. You probably have gout. He could have gout. But what's more likely going on here? Morning stiffness, effusions in his knees. This oligoarthritis affecting these different joints. Morning stiffness, inflammatory back pain. This is most likely, minimally, an undifferentiated spondyloarthropathy with peripheral arthritis and overlap of psoriasis, or it's psoriatic arthritis, and I think it's psoriatic arthritis. These effusions, these on and off fluid accumulations in some of the joints, in my experience, I think this is really interesting. I've seen it mostly in spondyloarthropathies. I'm sorry, I'm having a hard time speaking. I'm dehydrated and my mouth is dry. Psoriatic arthritis, ankylosing spondylitis, inflammatory bowel diseases, Crohn's and ulcerative colitis, and sarcoidosis. But I'm told I'm wrong in that regard by some rheumatologists I've talked to. But in my experience, it seems to be more spas. And so I say to him, continuing where we left off, you probably don't have gout. You probably have psoriatic arthritis. And his eyes light up. Don't worry, sir. You're not going to die tomorrow. What you need to do is go back to your primary care, who seems to be fumbling all of this, and get plugged in with a rheumatologist. And if she's treating you with allopurinol, that's like taking a water gun to a tower on fire. When you have psoriasis, there's skin cell turnover, there's a buildup of purines that's going to drive up your uric acid. And the levels are so high that allopurinol is probably not going to do much for it. And the better approach is to control the psoriatic arthritis. How do we do that? As naturopaths, we change your diet, we approach your lifestyle, we treat your gut, okay? If that's too much work or too much of an economic burden for you, then you need to get plugged in with a rheumatologist, okay? You probably should be plugged in with one anyway. And, because psoriatic arthritis can deform your joints and result in severe functional impairment later in life. So methotrexate, TNF inhibitors, stay the hell away from prednisone. That will really light your psoriasis on fire, particularly when you get off of it. A joint approach is probably best, okay? And he looks at me, he's so appreciative. We both spit out the wear and tear degenerative Kool-Aid, degenerative wear and tear CrossFit Kool-Aid, and we're guzzling a rheumatic, inflammatory condition sort of Kool-Aid, psoriatic arthritis. He walked out of the office very appreciative, and I sent him on his way. It's a case that highlights how your ears can mislead you. Thank God for my eyes. A lot of clinicians are asleep, and they're not using their eyes or their ears. Make sure they're listening to you, touching you, putting their hands on you, using their eyes, looking closely, asking more questions, okay? Especially of guys. Us guys are really, 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 really bad with our health history. We're poor historians. We think that substantial amounts of skin lesions covering our skin is not a big deal. So yeah, your clinicians really got to dig in. This is Dr. Mitchell signing off. I'm almost home. I'm so stoked for tomorrow. I'm going back to Tucson, going to the gem show, gonna climb some rocks. It's gonna be a great day. Everybody get outside, enjoy the sun, enjoy your Sunday. We'll talk again real soon. Bye-bye now.